The last section in Unit 4 starts with abruptio placentae, or an abruption. An abruptio placentae, or an abruption, is a premature separation of a normally implanted placenta before the birth of the fetus. Obviously, this will cause major effects to the fetus because of the fact that there will be reduced blood flow through the placenta, and which will affect oxygenation and nutrition to the fetus. Vaginal bleeding may be slight to absent or profuse depending on the type of abruption that you have. If you look in figure 14.4 in your book on page 365, you can see a concealed hemorrhage. There would not be any bleeding. A partial hemorrhage, or a partial separation, you may have slight bleeding, or with a partial separation at the end of the placenta, you would see bleeding from either a trickle to profuse bleeding. Again, if you refer to table 14.6 on page 362, you can see the different types of abruptio placentae versus placenta previas. The biggest difference between an abruption and an previa is that the patient still has vaginal bleeding, but they have persistent abdominal pain and uterine tenderness. These patients will be doubled over in pain when they present to the OB unit. They will have a hard board-like abdomen. They'll have systemic signs of early hemorrhage, including tachycardia and possibly decreased blood pressure. There probably will be signs of fetal distress, and it may lead into DIC, which is disseminated intravascular coagulation. Predisposing factors to an abruption include hypertension, cocaine use, methamphetamine use, alcohol use, cigarette smoking, poor nutrition, trauma to the abdomen, a folate deficiency, or prior history of an abruption. Basically, with an abruption, we have that premature separation of the placenta from the wall of the uterus. The treatment depends on the severity of blood loss and the fetal viability. Many times when patients present with abruptions, the baby may already be a stillborn. It may require immediate birth if we still do have a heart rate in the baby, but the baby will have signs and symptoms of shock. A vaginal birth is preferred over a C-section if there's no fetal distress or fetal death. If the baby is not in distress, obviously we want to try to have a vaginal delivery, or if the baby is stillborn, there's really no need to do a C-section, which is a surgical interventions. Obviously, again, with the abruption treatment, because we are dealing with blood loss, we may have a large bore IV inserted. We'll monitor for signs and symptoms of hypovolemic shock and fetal distress and provide emotional support to the mom. It's always important to let them know the interventions and what is going on during treatment. DIC is a large clot on the placenta that will consume the clotting factors with the clot on the placenta, which leaves the rest of the woman's body deficient. Basically, there's clot formation and coagulation that is occurring simultaneously in the individual. Bleeding may be evident from the nose, the mouth, any incisions, or any venipuncture sites on your patient. The treatment is to remove the source of the DIC through a C-section, which is the placenta, and replace blood and clotting factors in the individual with the use of blood products. Obviously, these would be ordered by the physician. Objective 58 says describe signs and symptoms and suspected etiology of polyhydramnios and oligohydramnios. Polyhydramnios is greater than 2 liters of amniotic fluid. It is associated with diabetes mellitus in the mom, GI tract disorders of the newborn, or neural tube defects of the newborn. Basically, the patient will measure large on their fundal height assessment at their prenatal care visit. And then their ultrasound from that large measurement will show polyhydramnios. Oligohydramnios, which is less than 300 milliliters of amniotic fluid, is commonly associated with renal disease of the newborn and also intrauterine growth restriction of the infant. Premature rupture of membranes, this is on page 496 and 497. These pages are in chapter 19, right after the preterm labor information. With premature rupture of membranes, there's a spontaneous rupture of the amniotic sac and the leakage of the amniotic fluid beginning before the onset of labor at any gestational age. Infection and umbilical cord compression are significant consequences of prolonged rupture of membranes to the fetus. Premature rupture of membranes. Preterm premature rupture membranes are membranes that rupture before the completion of 37 weeks gestation. Nursing interventions for preterm premature rupture membranes include education on meticulous perinatal care so that we don't have any issues with infection. The nurse will administer IV fluids if IV antibiotics and steroids is ordered, and then the nurse is responsible for fetal and maternal monitoring and report any abnormalities to the physician. Outline nursing care and management of the pregnant client experiencing emergent conditions. This is back now in chapter 13. With asthma, patients that are pregnant and have asthma, how pregnancy affects the asthma varies from patient to patient. Some patients actually get better and have less symptoms, some stay the same, and some get worse, and it is completely individualized as to what happens. The goal is to maintain adequate oxygenation to the fetus by preventing hypoxic episodes to the mom. So as long as mom's got good oxygenation, the fetus should also have good oxygenation. There is an increased risk for postpartum hemorrhage associated with asthma in the mom. If the mom has cystic fibrosis, the goal of the pregnancy is to ensure adequate nutrition and oxygenation to the fetus. Patients with cystic fibrosis may develop gestational diabetes and liver disease during pregnancy, and they will have frequent monitoring of their weight, blood glucose levels, hemoglobin, total protein, serum albumin, PT, and fat-soluble vitamins A and E throughout their pregnancy. Fetuses born to moms with cystic fibrosis are at risk for intrauterine growth restriction, where babies are not growing appropriately for their gestational age, from uterine placental insufficiency, UPI. With uterine placental insufficiency, again, the nutrients and oxygen are not crossing the placenta and reaching the fetus. These individuals will have kit counts started at about 28 weeks gestation and non-stress tests starting at about 32 weeks gestation to make sure that the fetus is doing well in the intrauterine environment. Pruritus. Pruritus is also in Chapter 13, integumentary disorders. The major symptoms is severe pregnancy-related skin diseases include pruritus gravidarum, which is caused by skin distension and the development of stretch marks or striae. They get very, very itchy. Pruritic urticarial papules and plaques of pregnancy, which is PUPS disease. This typically affects prima gravidas in their third trimester. It will resolve spontaneously after delivery, and the goal is to relieve the maternal symptoms. And you can see a patient with PUPS in figure 13.6 on page 326. Intrahepatic cholestasis of pregnancy is a liver disorder unique to pregnancy. The actual cause of it is unknown. It can cause meconium-stained fluid, stillbirths, or preterm birth, which is associated with this process. The treatment is with ursodeoxychloric acid and antenatal fetal surveillance with non-stress tests and fetal kit counts. Epilepsy is another disorder that can affect pregnancy. Epilepsy is a seizure disorder of the brain. There are many epileptic medications associated with increased congenital anomalies. So because epileptic medications are known to increase congenital anomalies, the physician will typically order one anticonvulsant agent and prescribe that in the lowest possible dose to prevent seizure activity in mom. The most important goal during pregnancy is the prevention of seizures so that we have adequate oxygenation to our fetus, and there will be fetal surveillance needed, especially for monitoring for intrauterine growth restriction, which will be done throughout the pregnancy. And this will be done, again, via kit counts, ultrasounds, and non-stress tests. Systemic lupus erythematosus is a chronic multi-system inflammatory disease that affects the skin, the joints, the kidneys, the lungs, the nervous system, liver, and other body organs. Before a woman becomes pregnant, they should be in remission from lupus for at least 6 months before attempting to become pregnant. And during pregnancy, the mom with lupus needs close observation for the development of hypertension, proteinuria, and intrauterine growth restriction of the fetus. Cholecystitis is inflammation of the bladder. The signs and symptoms that the pregnant person will complain of is fatty food intolerance, nausea and vomiting, colicky, abdominal pain, and fever. Surgery to remove the gallbladder is often postponed into the postpartum period, but a cholecystectomy can be performed during pregnancy, and if it is performed during pregnancy, then all the nursing interventions associated with an appendectomy are the same interventions we do post-cholecystectomy. Thromboembolic disease is the formation of the thrombus inside the blood vessel, which causes inflammation. The patient will complain of redness, warmth, or and edema over the blood vessel involved. Prevention is the key, especially pregnant patients on bed rest. Our interventions to help prevent thromboembolic disease include rest, elevation of the effective leg if there is a DVT formation in it, anti-embolytic stockings or TED hose, and the use of anticoagulation therapy in the form of heparin. Please let your instructor know if you have any questions.